I'd now like to invite onto the stage Dr. Janet Schloss, who is our next speaker. A little bit about you first, though. Janet is a clinical research fellow and lecturer at the National Centre for Naturopathic Medicine. She's an accomplished researcher with extensive experience in coordinating clinical trials. In addition to her academic career and research, Janet is also a practicing clinical nutritionist and naturopath with over 20 years' experience. Since 2015, she has started focusing on medicinal cannabis and has completed a major trial on glioblastoma and cannabis. Through her critical and rigorous research, she helps patients and practitioners to establish evidence-based practice. She is here today to talk to her presentation, Medicinal Cannabis Found Safe and Well Tolerated in Recurrent GBM Patients. Please welcome Janet.
Thanks everybody for having me. Can you hear me? Yep. I am going to present my results today on GBM and cannabis. And firstly, before I start, I'd actually like to thank two of my investigators and colleagues, Associate Professor Judith Lacey, and I don't know if he's actually here, but soon to be Dr. Justin Sinclair. So not only have they helped me through this particular trial, but they've also kept my mental health stable, so which is highly valuable. So before I start, what I'd like to say is this is actually an investigator-led project, and I was very lucky to get funding from Bioceuticals to be able to conduct it. So I appreciate all of that. However, yesterday I was hijacked by Dustin Sinclair, Sukla. And at first I was like, oh my God, it's actually our study. And then I was actually really chuffed because we had an American actually acknowledge an Australian researcher and what we actually do, which I think is actually really important. So it actually shows that we now actually have quite a number of really good researchers in Australia that are producing good quality research that's actually being acknowledged by Americans, can I say that, but also the world. So let's move on. One of the reasons that this is actually really important is it's a really poor prognostic outcome. And I'd like to just outline a little bit about what this is actually happening. So in 2015, I was actually talking to Justin and a couple of other people, including Andrew, and looking at what cannabis was coming, because I was seeing a lot of people coming into clinic who was actually taking medicinal cannabis. So we actually did a literature review and on medicinal cannabis and cancer, and found out that most of it was actually done on symptomology. But a lot of people were actually coming to us saying, looking at what does it have as an anti-cancer property. But not a lot of work was actually done in that area. What was actually done was mostly in the glioblastoma section. So in that, we started to delve in a little bit further. By the way, that was never published, which I'm sorry to say. So we started to look. There was actually one study that was actually done over in Spain, and that was in an intratumoral type response, and then the GW pharmaceutical trial, which was starting to look at it in conjunction with temozolomide, which is the main chemotherapy agent. So we started to look into, well, let's have a look and see what the gap is. So the main gap that we actually found was the tolerability, and that what if this patient group can actually tolerate a higher THC or a lower THC and CBD type response? We actually didn't know. So that's where we actually came from. It took us a long time, obviously, to get the ethics application, as you can quite imagine, but we were very excited to start. Now, having a look at glioblastoma, or GBM in particular, what we find is that over 800 people a year get diagnosed with brain tumour. Now that probably sounds like a lot of people, but it's only 1.4 of our population of newly diagnosed cancers every year. So it's actually quite small. But what the problem is that the mortality and the morbidity from brain cancer, particularly glioblastoma, is really poor. So these people, when they're actually diagnosed, only usually get given about a year to 18 months to live. And the reason for that is that there's a really high recurrence rate, and that it's really hard to treat because The glioblastoma itself usually cannot be completely removed. It has little legs, it actually spreads, and it has such a high probability of coming back. So anybody who's actually got the glioblastoma actually has a very poor prognosis. The other thing is, and I think this is really important, is that there's been no improvement in survival rates for over 3 decades in this population. You know, that again, I think is something that really needs to stand out. So what we need to do is how can we support the treatments that we currently have, and how can we make survival for these patients better? So current treatment at the moment is obviously debulking. It's first-line treatment of temozolomide and radiation, and then monthly temozolomide normally for up to 6 to 12 months. And then we have next line, which may be lomustine, Avastin, but again, most of these are having a poor prognosis. Hello, John Scarrett. Okay, the other thing is 4 Australians die every year of brain cancer, every day. So again, that actually shows the probability. The other thing is brain cancer kills more children than any other disease in Australia. So it's something that I think we really do need to actually focus on. So on average, like I said, in Australia itself, 1,750 gliomas are actually diagnosed yearly. Of that, a third are GBMs. So the chance of surviving over 5 years is less than 2%, 22%. And some of that is really low. Now, I want you to keep that in mind when I talk about survival later on, because I'm going to present some new data that hasn't actually been published yet. So our objective really is to look at what was the tolerability of 2 different ratios of cannabis for this population, a 1-to-1 ratio and a 4-to-1 ratio of THC to CBD. And they were actually randomized, which we were blinded to. Now, we didn't actually have a placebo. We were going to actually have a standard care. The ethics people said that wasn't fair because everybody would want to go into the cannabis group. So what we decided to do was actually have a retrospective study to see if we can actually compare what the outcomes actually were. The products that we actually used was actually designed specifically for our trial. Now I can thank Justin Sinclair for all his hard work to actually design these ones. So they're actually not commercially available, but that's what we were actually able to get in and to use. So we had one with standard treatment and a 1-to-1, and the other one was a 4-to-1. Now, everybody that was actually recruited has either recurrent GBM, so it's actually already come back, or they've gone through first-line treatment. They had inoperable cancer, so that they weren't able to be debulked at all, and that was showing potential growth. So again, you're looking at that poor prognostic outcome. We did MRIs at baseline and week 12. It was only a 12-week trial for each person, and they came in from every 4 weeks for that. Now, we only had one site, that was in Sydney. People flew in from all over Australia for this trial, which we didn't actually, and they got a whole $25 gift card each time they came. You know, that's not in comparison to what they're actually paying for what they did. So it was actually quite good, and then we actually had follow-ups. Now, we also got ethics for the follow-up to 2 years, and that's what I'm actually going to present to you today as well. So we've actually just got that data. We did a media release when this actually started in 2018, and we were absolutely inundated. We were not prepared for the amount of attention this actually got. We had over 900 people contact us, and we did not have the staff to do that. So it took us a lot of time to actually go through a lot of that. After all the filtering through, I think we ended up with like 260 that were actually eligible for it. We ended up having a wait list, which for people who've actually run clinical trials, this never happens. So it's like usually recruitment is such a struggle, but this was like over inundated. But because we had strict inclusion criteria, we had to go through what they had to do. We had to have the MRI to make sure that they actually met the conclusion. They actually had to have their liver enzymes and kidneys in range of the whole function. So we were able finally to get in. Overall, we had 91 people who actually came in. We ended up with 63 and 61 finished. We had quite a number of people who passed away suddenly what I will say is when we actually started recruitment, we actually had a delay in getting the cannabis from Canada into Australia. So we had 10 people who actually started the trial, because that's when we had started recruiting in, without the actual cannabis. By the time that we actually got the cannabis in, 2 of them had gone into palliative care. So we then actually had to exclude them. I then had to fly around Australia in 2 days to actually deliver the cannabis to make sure that they were given to the right people. So just to give you an idea of some of the logistics. So once we went through, we also had 21 people die during the actual trial itself. So that's what we said, like it's quite, it's a hard population, but we were trying our best with what we got. Overall, attrition rate of actually 30%, which is actually not bad when we look at this particular population group. Of that, we were able to also do some of the retrospective study. Looking at demographics, most of our age group was around 53. We had people who were only 18 or 19 that entered the study, up to 73. So there was quite a large range that we were actually dealing with. We had a huge amount of exclusion criteria, which is when we had to filter them through. And you can actually see that a lot of them were still on certain treatments, so temozolomide, lomustine, and avastin. Now, there's been no studies to date at this stage with cannabis and lomustine. So it was interesting to see, because this is a pilot trial and it is something that we are looking to go into. And we had to also look at the number of craniotomies. Now, just to take this in perspective, it was run out of Charlie Teo's office, so obviously he does a lot of surgery in regards to that. So you can see that some of them had quite a number. They weren't just recruited from him, they were actually recruited from everybody from around Australia. We had quite a number of oncologists who were sending them to us. Our primary outcome was the FACT BR. So that's what we were actually looking at, was part of their quality of life and their ability to tolerate the cannabis. What we actually found that overall, the total FACT BR was not significant. However, it was for the physicality, it was also for sleep, their physical energy during the day, and their quality of life. Now, this probably doesn't sound too much, but what we can tell you is that makes a huge difference in this population group. So we had a lady who was in a wheelchair. By her week 8, she was actually able to stand up for a little bit and move one of her arms. So that physicality is quite amazing. The other thing is that we had one of the ladies who came in, and if you know about brain tumours, they can be quite aggressive, they can change over their personality, which is quite disruptive for the families. So after week 4, the family came back and said, "Oh my God, thank you so much. We've actually got our mum back." So she was actually a lot more calmer. She was actually a nurse by background. She actually recognised it herself, and she said, "It's just so much nicer now to be able to interact and be with my family." So these type of things and the quality of life makes a huge difference. And we also did longitudinal, because obviously we lost a lot of people during the trial, just to see what the difference was. And again, we actually found that the physicality and the sleep made a massive difference for that. Yes, there's side effects. Now, this is an interesting group, because when we're looking at GBM, obviously they have physical problems already, or mental type problems because of the disease that they actually have. I have to say it's one of the easiest ones, because nobody drives. So we don't have that driving issue with this cohort compared to a lot of the others, which was pretty good. But we did actually see a lot of the normal type of side effects. So the dry mouth, the tiredness, dizziness, and drowsiness. We had a couple of people who did actually have some paranoia, which Dustin actually said yesterday, and hallucinations, which we actually had to reduce some of their dosage. So what do we find for efficacy? Like I said, we actually did an MRI at baseline and 12 weeks. Now, 3 months doesn't sound like a big deal, and it's not like a longitudinal type study, but when you kind of think about it, these people only have usually given like a year to 8 months to live. So 3 months is actually a reasonable time to actually assess things. So what we actually found was that 45% of people actually had stable disease or reduction in disease. So, which is actually quite phenomenal when we're looking at recurrence. We did have some that actually had progression as well. So I don't think that cannabis can work for everybody. I will also state that I don't think that cannabis can cure cancer, but I think that it has a benefit for certain people and can work in conjunction with certain treatments. And that's exactly what we actually want to see. And talking with Dee Dee as well, I think that they're, some of the work that they're doing, and if we can actually incorporate that into our studies going forward and the type of cannabis that we can actually use, finding out also, some of the genomics so that we can say, well, this person's actually get benefit and this one may not, may also help with trials progressing forward. Our retrospective study, unfortunately, we can't really use a lot of this data because we actually got it from Charlie Teo's group. They had more numerous surgeries and they were on high amounts of DEX, exactly what Dustin said yesterday. However, when we do actually look at the difference, when they were actually matched, a lot of them actually had a lot more progressive disease versus our stable disease in that same time frame, and none of them actually had reduction in disease. So it does show potential. So what do we believe? So overall, I believe that, and from the study itself, it does not cure it. What we saw was that people who were really more advanced, it gave them a little bit more quality of life, probably towards the end, but it didn't actually stop the progression of their cancer. People who were actually in treatment, it actually seemed to actually help reduce their tumour growth or keep them actually stable. And I think that's actually really important. But most importantly, it actually helped with their quality of life, their physicality, and that's what I said, every day is really important. Their ability to communicate and interact with their family. I still get calls today of the families to ring me up and stuff like that and say thank you for being part of the trial and what a difference it actually made to their life with what they had. And that's for some of the people who also had passed away. I still talk to some of the parents of some of the younger kids as well. So I believe that it is something that we can look into in the future. Now, overall, we believe that 1:1 is probably the better ratio to actually use compared to the 4:1, and that would be what we'd be using going forward. Now, what we found was a low dose, and I think that's actually really important to state because a lot of anecdotal type data that's actually out there, particularly in this, is saying you need really high doses of THC to be, cure the cancer or fight the cancer. Well, that's not always the case, and more is not always better. And I think that also comes down to the individuality of the person and how they actually process some of the cannabis. Now I'm going to show you some of the stuff that's not been published. So one of the things we actually did during the trial was actually take blood samples. And in our blood samples, we did from baseline 4, 8, and 12 weeks. So we were able to work with Nickam and Mitch Lowe, and we looked at the endocannabinoid system and the cannabinoid system in each of those. I'm not that far off. And so this is some of the data that we think, and what we're going to do is actually get with Mitch, but I've also been talking to Dee Dee and try and work together to try and analyse this type of stuff, because at the moment all we've got now is the PK data, which you can actually see. So what you're seeing is a whole range of different aspects between the endocannabinoid systems and the cannabinoids and the dose itself. So I've just brought 3 different types of people so that you can actually see, there's no correlation. There's always seems to be a whole range, which is why we need a few more brains into this to try and analyse this so that we can then publish this type of data. So the thing you will notice is the 11-norgluc, which is obviously the biochemical process from the THC, so you can see that they're definitely processing that. But the rest of it, like I said, we actually need to have more work to get together. this is the most exciting part, I think, that I get to tell you. So our survival data over 2 years, of which we actually collected and we talked to them every 6 months, actually showed that we still have, post-trial, 47% still alive. So of that, only 2 are not still taking cannabis. So that's actually phenomenal, which basically means these people have nearly got to like the 3 to 4 years post-diagnosis. So that's not post-diagnosis, it's post-trial. So, which is actually, like, I think, absolutely brilliant. So where to from here has been talking to Judith and some of the people over here. We're going to get another ethics applications because our ethics basically took us up to that 2-year follow-up. And what we'd like to do is now get access to their MRIs from their doctors. We're going to do a quality of life with their carers to show that and see if we can actually follow these people up for another 5 years to see what actually happens. Because that to me is actually a really good sign. So in summary, these people basically are exposed. They have a lot of symptoms, both from their disease, from the treatment, and from the progression. Cannabis has the opportunity to actually help not only their quality of life, their physicality, but everything that goes along with it and reducing a lot of those symptoms. Sleep is so important for these people. Remember, it's a 1 nightly dose, so their quality of life through the day was actually exceptional. It still remains a very vulnerable group, and I think an area that we seriously need to do a lot more study on. And, you know, I think that 1 nightly dose is good. They can function throughout the day. They're not tired. Their actual cognition was actually by far better. And that makes a big difference. Flying away. So yes, a single nightly dose of a 1-to-1 preferably of THC to CBD, that's individually dosed. There is no one dose for one person. We did a titration period to find out what was their right dose and then they stayed on it. Was found to be beneficial for their quality of life in particular and physicality. This was our last day of the trial. Just showing some of the people. The lady up in the far corner has now gone over to New Zealand. We were having trouble trying to connect with her. 2 weeks ago, she sends me an email, goes, "Hey, I'm still kicking, and guess what? The bastard hasn't got me yet." So she's still there and alive. I have a lot of people to thank. It takes a tribe to run this type of trial. To me, I find it probably one of the most hardest but the most beneficial trials I have actually ever conducted. I really wanted to be able to do the next step. I know that GW Pharmaceuticals are now up to their phase 3 type trials, but I think that we have the opportunity to show that it's not just side effects that can actually help with them. It can actually be other products, but so be it. But the funding, like we have obviously put in grants and stuff like that, but I believe that this will happen. You know, blue sky and all the issues that actually come across, I don't care. I believe if you believe in something and you want it to happen, you will make it happen. And I believe that we'll be able to run another trial. Thank you very much.